In this lecture, we will discuss screening and prevention of heart failure, including why, how to, and who to screen for heart failure. There are three questions we will briefly address in this lecture. That is, why screen, who to screen, and how to screen for heart failure. The first question is, why is it important for us to screen for heart failure? Well, screening for heart failure is important because it is well established that treatment of asymptomatic LV dysfunction or left ventricular dysfunction, 1, improves cardiac function, 2, delays the onset of symptomatic heart failure, and 3, it reduces morbidity and mortality associated with heart failure. In addition, it has been shown that heart failure incidence can be reduced significantly by lowering blood pressure in those at risk. The American College of Cardiology, or ACC, American Heart Association, or AHA, and Heart Failure Society of America recommend targeting an optimal blood pressure of less than 130/80 for heart failure prevention. Okay, so again, that main question of why we screen, well, we've seen that there are, in fact, good things that come from it. Improving cardiac function, delaying symptomatic heart failure onset, and reducing morbidity and mortality. And this is that blood pressure goal to decrease that incidence of heart failure. The next question to address is, who do we screen? The answer to this question is still quite unclear. In general, screening at-risk patients is a good place to start. In other words, patients with cardiovascular risk factors like hypertension, coronary artery disease, diabetes, valvular disease, current or former smoking history, and so forth. Okay, so that's the question of who do we screen. Again, mostly unclear, but we want to screen our at-risk patients. They're most likely to develop heart failure. Lastly, an important question is, how do we screen for patients with heart failure? Unfortunately, there remains no accepted cost-effective approach to identifying and screening for asymptomatic LV dysfunction in the community. Remember, heart failure is a clinical diagnosis. Therefore, if a patient presents with symptoms of heart failure, you already are too late. Currently, natriuretic peptides are considered the most robust predictor of heart failure, with nt-probnp being the most sensitive of the two. Oftentimes, BNP will be used to diagnose or exclude heart failure, but this is certainly not perfect, and it is not uncommon for patients to have an elevated BNP and undergo echo, that is an ultrasound of the heart, and have no evidence of cardiac dysfunction. Sometimes studies have shown that aggressive guidelines-based therapy in those with elevated natriuretic peptides can help prevent future LV dysfunction or new onset heart failure. A new screening tool showing promise is the application of artificial intelligence to the electrocardiogram, or EKG. In fact, some of our current work with artificial intelligence here at Mayo Clinic is showing robust predictive value of AI, that is artificial intelligence application to the EKG to identify asymptomatic LV dysfunction. It's actually even outperforming the current most robust predictor, as we mentioned, nt-probnp. Now, this is still in the infancy stages, but it's quite remarkable, and so stay tuned for that. In conclusion, additional research is needed to identify cost-effective screening interventions for heart failure. So let's briefly review what we discussed before we end here. So we mentioned three questions with screening and prevention. That is, why do we screen, who do we screen, and how do we screen? The first one of why do we screen is because we know that treatment of ALVD, which is asymptomatic LV dysfunction, okay, improves cardiac function, it delays symptoms or symptomatic heart failure, and it reduces morbidity and mortality. We know that if we control blood pressure, those that are hypertensive or at risk, to less than 130/80, this decreases and reduces the incidence of heart failure. So who do we screen? Again, we said that this remains quite unclear, but if we choose the ones that we should probably screen, those are those that are at risk and most likely to develop heart failure. Okay, so hypertension, remember, shooting for that goal if they do have hypertension, coronary artery disease, diabetes, valvular disease, and smoking history, whether it's current or former smokers. And how do we screen? Again, No cost-effective or accepted approach exists to identify and screen for asymptomatic LV dysfunction in the community. Okay, remember, we want to catch these before they develop symptoms, and we know that if we treat those that before they develop symptoms, this delays that onset. So it's really important too. nt-probnp and some of those natriuretic peptides are often used to diagnose or exclude heart failure as a cause of dyspnea, and we'll discuss that in future lectures a little more of different levels and how they're important. But still, it's still not the best one, and oftentimes we'll do more echoes and just increase the cost. So remember, what we have going on here at Mayo is this application of artificial intelligence to the EKG as a potential new screening tool, and it's amazing. It's even outperforming nt-probnp in our community here. Well, that's the end of this lecture. We discussed screening and prevention of heart failure, including why screen, how to screen, and who to screen for heart failure. I hope you learned something.